So thanks the audience for coming back for these sessions. These sessions is plenary sessions on the CNS tumor. So these sessions will have altogether 6 speakers. Our first speaker is Dr.
Hernaiz.
Hernaiz, yeah. I'm very forgetful. So, and Dr. Hernaiz will be talking about low-grade glioma and the modern strategies of diagnostics, approach, and treatment.
Okay, thanks, Michael, for the introduction. Thank you very much for the organizers, especially Ella Komirova, for giving me the opportunity to come here and to talk about this topic that is part of my everyday work. Before going into what there are new things in diagnostics and therapy, I just want to make sure you have the key points of today, and then just after that slide you can leave if you want. Okay, so it's the largest subgroup of pediatric brain tumors, and in about 15% of the patients that we're treating, we find genetic syndromes. The most common one is the neurofibromatosis type 1 and the tuberous sclerosis complex, but there are also others that we have to care for because they may even mimic N of 1, like the biallelic mismatch repair deficiency syndrome. It's a chronic disease. That means we have a very good overall survival and a very low EFS. That is, the tumors keep on progressing, and some, especially the unresectable ones, can experience multiple progressions. And the patients face then severe loss of function, vision, neurology, endocrinology. And what we have to bear in mind, it has a tendency to turn malignant very rarely. The RAS-MAP signal pathway is the real driving tumorigenesis pathway in almost all LGG. So if you just, now you can snooze or whatever, but anyway, so I'll be more elaborate on that. As already said, it's the most common tumor. In 2001, in the German Children's Cancer Registry, 40% were astrocytic tumors and 80% of them are low grade. So the low-grade classification of 2007 was already a changing one. There was an introduction of the DNT in 1993 and the angiocentric glioma in 2007 for the grade 1s. For the grade 2, that is also part of the low-grade glioma, we had also newcomers in terms of the pleomorphic centroastrocytoma in 1993, as well as the palomyxoid astrocytoma in 2007. And now in 2016, some of our friends are going, that is the protoplasmic and the fibrillary astrocytoma variants, and we have new friends that we have to deal with, or enemies, if you want to put it that way. That's the diffuse leptomeningeal glioneuronal tumor, the oligodendroglioma, IDH mutant and 1p90q co-deleted, as well as the diffuse astrocytoma that can be either IDH mutant or wild type. Concerning the localization, you're all pretty aware of that. The majority of tumors arise in the midline. We have very few in the hemispheres. We have quite a bunch in the cerebellar area, and we do have, and that's important to think about, especially when we think about the just recently introduced histology entity of the diffuse glioneural tumor, and you can see it here, that we have up to 5% depending on the series of primary metastatic low-grade glioma. So in the 1996 study that was published in 2012, and you know I'm from Germany, you can see the flag there, we had 2 big studies run. One was, as I said, already mentioned, 2012. It was the 1996 study. And it shows already the difficulties as well as the strengths of the study. You have about the majority of tumors are pilocytic astrocytoma, and in the CV trust it shows that it's a very high incidence, and it was almost 1 patient per 100,000 per year. And then you have a significant group that is not properly put into an entity, and we do have another group that is just followed without having any histology at all. That is only by setting the the diagnosis by imaging. So in the 1996 study was that children younger than 5 years, we wanted to postpone or in case, if it's possible, to completely evade radiotherapy. And so by using for 12 weeks carboplatin and vincristine, and for the ones that were supposed to be older than 5 years, to use radiotherapy as a first-line treatment, which was so far the common approach. And and as you can see, we've been collecting about 1,000 patients, but only 1 out of every 3 patients needed adjuvant treatment. And in the end, it turned out that the majority was treated with chemotherapy, and of course these were the younger ones, these were the older ones. And as you can see here from the range, with the time going by, there were older patients that were included. Now this is what I already mentioned. We have an excellent overall survival, not really excellent because there are still about 10% of patients that we lose within the first 20 years after diagnosis. And then what we do have here is the tendency for the tumors to progress. But that means at the beginning we have quite a bunch that are progressing, but then we have also late progressions, which means that a lot of patients do not progress up to 10 years after diagnosis. This is important to bear in mind. And that sets the stage for this slide here, where we can look at it. What does surgery do in all this? When you look at complete resection, we do see that is actually doing the job. That is, the resectable tumors are manageable by that, but still some of them recur. And on the other hand, even if we do biopsy, of course, we do see progressions after biopsy, but 1 out of 5 patients for about 15 years does not have a progression, which is important to bear in mind when you deal with these patients. Looking at the event-free survival, we do know that the under ones are the ones that are really progressing. And when you look at the result, what does progression-free survival after chemotherapy or radiotherapy, you see that radiotherapy in that sense is achieving a much better PFS than chemotherapy. But our aim was, and as you can still see, at least 4 out of 10 patients after 10 years do not need any radiotherapy. When you look at it in terms of progression-free survival, what role does NF1 play? You can see very clearly that NF1 positive patients respond much better to the chemotherapy than NF1 negative ones, and especially the patients that have disseminated tumor, that have a diencephalic syndrome, are younger than 1 year, are the ones that also do not respond too good to chemotherapy. And then in general, you see that is also something very important. That is not only the under ones, but also the patients older than 11 years do not respond properly in general after adjuvant treatment. So these were the strategy groups that trickled out from this study, and you can see here we have this very high-risk group that is the patients that are younger than 1 year. We have the standard risk group that is defined by polycystic astrocytoma, an age between 1 and 10, and then we do have the median risk tumors that are the diffuse astrocytomas, and of course we have the 4th group that is the NF1, and as well and in addition all the others. So, and then in the 2004 study that was already set up when we did not know yet all those risk groups, the story was that we thought that if we give more chemotherapy, that is intensified induction with 3 drugs, that in addition to carboplatin and vincristine, we give etoposide, this would do the job. But I can tell you it's just finished, and the paper the manuscript is actually written for the moment being and submitted soon. There were about 3,500 patients that we were able to collect in Europe. Again, 1 in 3 was only treated with non-surgical therapy. That is about 1,000 chemotherapy patients, and about 500 were randomized. And what you can see here, this is pretty clear cut. So you don't get more results, better results by adding a third chemotherapeutic drug. And this is not only for the progression-free survival, but also for the overall survival. So when you bear in mind, we have a tendency that the tumors progress, but it's a chronic disease, then we have to look at function. And you can see here, legal blindness there's an increasing cumulative incidence. The same is due for the visual function, hearing loss, endocrine dysfunction, and especially also for patients with obesity and metabolic syndrome. And the number of seizures are also increasing for the time. So function is very important. Now, the Canadian group has been looking at their data also nationwide, and they found out and found the same things out that like the Americans did, that upfront radiation treatment was a big hazard risk factor for death in general, and especially for tumor-related death. But about 2009, the stage was set by the group in Heidelberg, and then also others, that they found out for the very first time that there is a driving event in the low-grade group, especially the polycystic astrocytoma, is that almost in any low-grade tumor, especially polycystic astrocytoma, all these pathways are activated by either point mutations or rather fusions. So we find a lot of fusions, mutations, especially in the cerebellar area, whereas where you go towards the hemisphere, we find much more BRAF mutations. But in the end, we do have an phosphorylated ERK activation, which then leads to growth of cells, differentiation, as well as oncogenic-induced senescence that explains, although there is a strong driving moment, these tumors are slowly growing tumors. So, and this is to highlight a little bit the BRAF. So we have the kinase domain that is very promiscuous and then fuses especially to the Ka1549 exon. There are several different exons that may connect here to the BRAF. There are other ones that all lead to a constitutive activation of BRAF. And there are preliminary results that indicate that, especially depending on the different exons that are connected here, that we do have a different impact on the biology of the tumor. Then in the next paper, Jones, then they published where they looked at much more thorough into the genome of the tumors, and they found out that they're mutually exclusive BRAF mutations and other mutations that they were able to find that all at the end funnel into the activation of the mitogen activated protein kinase signal. So by knowing this already, there was a study set up in the US led by Karayanis where we thought sorafenib would be doing the job. Sorafenib is inhibiting, in a way, especially BRAF V600E, and in addition, it interacts also with the c-KIT and other parts of the microenvironment in preclinical studies. And what turned out, this is the group, and I just want to keep you in mind that these information on the BRAF status, where you can see that none of them has the V600E mutation, came out after the study. And that is what came out. I want to need to just push too much. And what you can see, the study had to be terminated prematurely because many of the patients progressed despite treatment with sorafenib. And it seems that sorafenib led to an activation, cross-activation of other pathway modulators that then allowed the tumors to grow more strongly than they were supposed to. So, but there are still ongoing trials and that are targeting different parts of low-grade glioma, Achilles tendons, that would be looking here at there are MEK inhibitors, and we're looking forward to have the data towards the end of the year from the US group, and there is an mTOR inhibition study, especially in low-grade glioma for NF1 patients, and there are also other ones where we target then the V600E mutation. The problem is that when we look, oh yes, sorafenib didn't work, so we take the next step towards MEK inhibition. We have to bear in mind that this pathway is a very complex one. And normally what happens that is self-negatively regulating. And this has been already found out when you use these two inhibitors, and they just inhibit the phosphorylated MEK1 and 2. But what happens here is that here you lose the feedback loop. So that especially if you do have RAS activation over here, then by the time you have an adaptive resistance that passes by the inhibited activity through cobimetinib or selumetinib. At the moment, the commonly available trametinib is actually the so-called feedback buster, where we do have an inhibition already at the MEK1 and 2 level, and that inhibits also the activation of MEK by RAF, the proteins, and especially heterodimers. Okay, but setting the stage for the new drugs, we have to bear in mind that in tuberous sclerosis, there it works. Because I will show you, then we do have a constitutive mTOR activation because either TSC1 or TSC2 is not activated, so there is this stop missing, and the patients develop low and slow-growing tumors. And the AXIS-1 study randomized the activity of everolimus against placebo. And what they found out is then that it was active. So they extended the study, and I'll show you the extended study data. So these are the data about 4 years of treatment. 108 patients were evaluable, and none of them progressed. You can see that at least 3 out of 4 had a more than 30% SEGA reduction, and almost half of them had a partial remission. The adverse events were acceptable. There were very few grade 4 problems. There was no effect on either sexual development or physical growth. So the take-home message is here that we do have a stable SEGA volume reduction up to 4 years. There was none of the patients needed surgical indication. The everolimus was almost well tolerated, and there were no new adverse events rather than when compared to the phase 2 study. Okay, so putting all this together, I just want to present the current status of the European protocol, our thoughts that we do have. So putting it together in a nutshell, it's a chronic disease. We see that brain function matters and that biology is key. So we'll care, this will be again a basket for all LGG patients. And we'll have, as you can see here in the middle, we'll do have a randomized trial, and we look forward to have also an N-of-1 randomized trial that is still in debate. And so what will be the aims of the trial be? We want to reduce neurotoxicity, which is considerable in the previous studies with using carboplatin and vincristine. And we introduce a combined primary endpoint because biology function is key. So we look at what happens to progression-free survival when evaluated just looking at the tumor. We look at neurological function as patients have tumor on different parts of the brain. We use the Violent Adaptive Behavior Scale, which then takes everything what the patient can do together, and we look specifically at visual function, and we use a protocol that will be used both sides of the Atlantic so that we can compare our data also with our American colleagues. So will be putting mandatory that all of the tumors will be analyzed by molecular biology, and we'll try to introduce a targeted compound where we're still working on. So this is what it looks like for the moment being. So we'll have a standard arm of vincristine, carboplatin, and we still don't know what works better, either 12 months or 18 months. This will be compared to a monotherapy arm with vinblastine, and that, again, 12 versus 18 months. And what we look at is we try to get a MEK inhibitor. We've sent out letters of interest to the pharma, and we wait for the final phase 2 data in the different trials that I just mentioned. So hopefully within the next year, we then come up with a definite protocol. So this is a whole set for 19 European countries that want to take part. And what in the registry, which is more or less my part, will try to get a new model for analyzing the disease. That is to say, every patient comes in here with a diagnosis, and then he may get different surgeries, and these different states then will be analyzed in their probability. At the moment, we just look at, we have either EFS, that means from diagnosis, this way or that way, that is to say when we start any treatment. And then when we look at PFS, this is from here to there, or up to here. That is another non-surgical intervention, which means that we have a limited sight at picture of these patients. And by introducing this model, we can much more reliably reflect the chronic disease and of the patient. Okay, and that's it. And I hope I can take some questions. I almost used up my time.
So I think in the interest of time, we can take only one question.
Very informative talk. You're talking about the tuberous sclerosis, Everolimus. So any study to compare sirolimus and Everolimus in the SEGA situation?
So far there has been no randomized study, and of course the first studies were done with Everolimus, and rapamycin, but for the moment being, this has been pretty much pushed by the pharma, and everyone is using the Everolimus. So far, the toxicity profile is acceptable, and we care for several patients, and we're pretty happy with that, and the results are reproducible.
So, I mean, just short response to that. So, there are several classes of mTOR inhibitor. Do you think they are different?
That has to be honest, we have to find out if there are better ones that may then lock in the tumor, because as for the moment being, we know when we take them off the study, take off the drug, then the tumors regrow. But maybe we find out an mTOR inhibitor that may do a job in the long term. So far, there is also no concrete concept on how to treat patients in the long run. These patients have been treated continuously for 4 years, but maybe we need lower levels, or we can even introduce concepts where you take holidays from the drug, and then go back to the drug.
So, can I just ask questions following the questions on the mTOR inhibitors? So because, well, the use of the mTOR inhibitors, 4.5 mg per meter square for the SEGA, so the pivotal trial only quote the follow-up of around 3 to 4 years. But as you said, well, since the tumor may recur or comes back if you stop the mTOR inhibitors, so it's likely to be a long-term treatment. So do we have any longer-term data to show the safety profile of these drugs to be used as a long-term treatment?
The ones that I just showed are the longest ones. For SEGA, these are the longest long-term results that there are so far. Yeah, and I think this is this will, and the indication has been now expanded in terms because they've been able to show that patients with heavy seizure problems, that also that they profit strongly from the Everolimus treatment. And the question would be is how much, what's the trough level necessary for seizure control with Everolimus, and what is the necessary lowest level for tumor control? This is something that could also be a topic. Yeah.
Thank you.